what we want to do in the next hour and a bit, is go over the results from the survey that we alluded to earlier. This survey was sponsored by the American Association of Colleges of Nursing, AACN, and the Institute of Pediatric Nursing. And another person that I want to thank on this is Dr. Judith Ryan, who did the analysis for us. She's very, very helpful. Where is she? Where are you? There you are. Oh, good. Okay. She really has been incredibly helpful in putting all the analysis together and the PowerPoint, et cetera, so we really do appreciate that. What happened, and I kind of alluded to this earlier, we started talking about needing to follow up on last forum and the request from the group that we look at undergraduate pediatric education. And again, in my naivete, I thought there was a lot out there, and there is a lot out there, but there wasn't a lot out that answered the questions that we had, which is, what are people doing right now? And so, as true of all good academics, we decided we needed to do a survey and do some research and try to find out what's out there. So the purpose of this was to understand the nature and scope of pediatric nursing content and clinical experiences currently included in undergrad nursing programs for entry-level RNs for peds. So that's what we're really interested in, okay? Now, a little bit of background. I have a dream, and my dream is that there will someday be a Hartford Center for Pediatrics. Now, many of you don't know what the Hartford Center is. The Hartford Center is a group that has funded geriatric nursing. They have funded it hugely, hugely, lots and lots of funds. And they are putting it into developing academic centers of excellence, research, education, doctoral students, et cetera. Quite a bit of funding into this area. And it's wonderful, and I love it, and I love my Gero colleagues, and they've done some fantastic things. But we need something like that in pediatrics. And our hope is that this will hopefully evolve into that. However, whenever you're doing anything, you want to learn from those who've gone before you. Well, our geriatric colleagues before the Hartford Center existed, much of what they did is what we're trying to do now. They went out and said, well, what's going on with geriatrics in undergrad education and graduate education? What are nurses doing related to geriatrics? And so we contacted our colleagues. We got the original surveys that they carried out when they were looking at this information and decided we will start from there. So one of the first things that we did was we talked to our colleagues in Gero, got the other surveys. We started to develop the surveys that we thought, the questions that we thought would address what we wanted to address. We brought in other experts. We piloted it. We went out to the other schools. So we put together a survey of 39 questions, very basic. We put them out on SurveyMonkey. SurveyMonkey did we use, I think? Yeah. It's not perfect, but it's a beginning. And it's a beginning to open up the door and get a better feel on what's going on out there related to undergrad peds nursing. So I'm going to spend most of my time, on showing you what the results were to that survey. We emailed this to 596 undergrad nursing programs on the AACN membership list. And again, this was where AACN became incredibly gracious, because to do this effectively, when you basically are an organization with very little resources, you need partners. And AACN was very helpful and was very willing to partner with us. We did quite a few phone calls back and forth, and I really would like to thank them. That was wonderful, Joan, so thank you. Pardon? Yeah. Oh, okay.
That was an amen.
Yes. So we had the 596 undergrad programs. We had 460 surveys that were returned. 66 of them were duplicates, and by duplicates, you might have had two people in a program that for some reason ended up answering it. We then had about 394 schools that really were good data that we could start working with, so a response rate of about 66%. We then looked at the data, or Judy did, and we started to eliminate a few things. Schools with less than 10 students we removed, which seemed logical. Surveys that had not completed the first 14 questions as a minimum, because as is true in all survey research, not every item was answered by everybody. And so of the remaining 344 schools, 88% completed the entire survey, but some did some parts of it. And looking at the data, we're going to present to you in three areas. We're going to first show you what the description is of the schools that are educating undergrad peds nurses. We're then going to talk about the faculty and then the curriculum. Now, for me, I have some ideas of what's going on out there from talking to people, but I had no data, and so hopefully this is the beginning of the data. So, for example, I had heard from a lot of people, and from my own setting, that it's difficult to get faculty in general and in peds in particular, that students are not able to go to pediatric experiences, and so people are starting to say, well, let's do alternatives, or let's just cut pediatric nursing. Let's not include it in the curriculum. So there are a lot of things like that we're hearing out there, but I don't know what the reality is. And so this is our first effort, and it's just a first effort, to try to understand what's really going on out there, what the experiences are of the whole group. So the schools. We'll first just describe to you the schools. This is across the areas, and you can see the Midwest is more represented in our responders to this than are actually on the AACN list, but a fair distribution relative to the AACN list. So the green here is what the distribution would be from the AACN list, and the red are the responders to our survey. So a few more from the Midwest. We're a very compliant group. Again, this is not going to be a surprise to anybody, but the location of the schools, as you can see here, most are in the urban area, and then it goes down to suburban and rural. So the majority, 50%, are in cities. This is of interest to me. I work in a large medical center, so 77% are not affiliated with large academic health centers. And that's important, especially for people like me who get stuck in this idea that everybody walks across the street and has an enormous children's hospital, et cetera. In fact, the vast majority do not have that, which may play into what we're hearing rumblings of. It's hard to get pediatric sites. Financial support, or how the universities are supported, basically it's 50% public, 50% private. And I was surprised that there were that many privates, but again, I'm in a public school, and I've been in public education for a long time, so I hadn't kind of realized that. The other thing that surprised me is that 25% is religious, so half of the private is religious, and I'm assuming that most of those, but that's probably my assumption, a lot of those are Catholic schools, like Boston College, et cetera. So, Mercy. Types of program, again, I live in a world with graduate and undergraduate, and I start to make assumptions that that's what everybody is, but more than a quarter of the programs are undergrad only, and then when I start working with my state, I start to realize that makes sense. There's a fair number of people out there that are undergrad only, but more and more pushing towards graduate education along with undergrad. This question, I think, is a little fuzzy. You know, you always do a survey and then think, I wish I asked this one a little bit, we asked this one a little bit differently. 19% combine campus and web-based education, but 81% are on campus only. Can you tell that? It's kind of hard on those slides, isn't it? The coloring is hard to see. So on campus only is the 81%. And combined is the 18 or 19%. For me, what we didn't tease out, and I would guess that any other educators, for example, I don't know how my folks answered this question, because all of our courses have some kind of web-based component to them, but it's on campus. I mean, people are there. So I'm not sure which side of this they went on, and I would guess that that might be true for some others. So my experience, and I'm not sure we've answered this correctly, is that there's a real trend towards, at minimal, not just having on campus, but integrating some kind of web-based programming. You may have a class that's totally web-based, but the whole program isn't, and so you have to be on campus. And that's different than totally web-based education. So we may not have teased that piece out as well as we should have. Full and part-time students in undergrad nursing programs. This is the number of the students themselves, and you can see the range is amazing. I kept thinking the 2,000 didn't make sense, but there are a few. Yeah, there are a few really huge programs out there. This is undergrad program size, and we divided the schools into small, medium, large, and very large. So the small schools are schools with just 10 to 150 students, medium 150 to 300, the large are 300 to 500, and the very large are over 500. So quite the range. I always find it amazing when I talk to our undergrad students, because we have 60 in every class, so we're one of the larger programs when we add them all together. And my graduating class had 12. So I came from one of those small ones. We wanted to look at program characteristics, and these are some of the areas that we were looking at: associations. We wanted to look at size, how they were financed, whether or not they were part of an academic health center, looking at things like region, location, type of education, standalone, difficulty with recruiting faculty, et cetera. So we wanted to look at some relationships here. And the characteristics related to the size of the programs that were significant. And again, some of this, you know, when you do research, some of this is like, well, I knew that, but now we have the data that we know some of this stuff. So small programs were less likely to be part of a large healthcare academic center, but the large programs tended to be. And that fits with some of us who teach in the CIC or the Big Ten kinds of schools. We have huge programs and we have huge medical centers that we're a part of. Large and very large programs were more likely to be in urban settings. Small were more likely to be in rural settings. So that again makes sense. If you're in a big city, you've got the facilities, the ability to be large, you're large. And some of the smaller schools tended to be in more rural areas out there. Small programs more likely to have undergrad programs only. And again, that intuitively makes sense. When you're going to move into graduate programs, you're starting to talk about people doing research and a different level of education, a different level of resources, and those are going to tend to be in bigger cities, bigger academic settings, that sort of thing. So none of these are a surprise, but it's nice to be able to confirm it. This is related to the support for the schools, and this is just looking at public, private, religious, in terms of where they're located. And I was surprised that we had, in the Midwest, so many private religious schools. I have to go back and look. That was, yeah, that was startling to me. So this gives you a feel of the breakdown. You know, one of the things I didn't say to you, and I'm seeing a few people flip through their slides, the handout that you have in your packet doesn't have every slide on it because there are so many slides. So we gave you sort of the highlights. But we will put this on the website. So you're probably better off now just, and we're videotaping, which will also be there. So, but it was a lot of slides. Programs with the religious financial support, again, were less likely to be part of an academic health center. Intuitively, that makes sense to me. Public and private non-religious funding programs were more typically, and actually the big health centers are typically with public schools. Programs with public funding were less likely to be in rural locations. Again, makes sense compared to some of the private religious schools and religious schools. So some of the descriptors of the schools are things I think we probably would have expected, but it's nice to be able to get a feel for that. So basically, if a program is part of an academic health center, it's more likely to be in an urban area, have both grad and undergrad programs, and deliver content both on campus and web-based distance learning. And I'm guessing that last bullet is really a combination. I'm suspecting most of them are really on campus, but they're enhanced by web-based education, and that's what my experience has been. So that's a picture of the schools of nursing. So our next questions were, okay, that's who we're talking to. What's the story with faculty? And this is particularly driven by our hearing that, well, we all know there's a faculty shortage, but we're also hearing that it's particularly a problem for pediatrics, so we wanted to explore that. And then we're going to move into from that into, and what are they teaching? So I'm going to let Jan do some of this.
Thanks, Anne-Marie. How many of you actually filled this questionnaire out? Wow, nobody. Oh, you did. Thank you, Deb. Thanks, Deb. 39 items. We estimated that there was about 20 or 30 minutes. Is that fair to say, Deb? Say that again. How long did it take you to do it? Okay, 20 minutes or so. Very good. Just 39 questions. Well, one of the things that we did particularly was have a lot of questions about faculty because we thought that that was an important thing to look at. And one of the things that we all tend to want to do when we're talking about faculty and students in combination in an academic center is sort of begin to think about faculty to student ratio. It's a very hard thing to do. It's often hard for faculty to report this as well. But our first question really dealt with how many faculty do you have just teaching undergrads, not necessarily pediatrics, but in your entire undergraduate curriculum, how many do you have? Interestingly enough, we have a mean of 33 combination part-time, full-time faculty. Sounds like that might be fairly reasonable. The range went all the way to 200 faculty, and you might expect those programs with 2,000 students to have 200 faculty. Certainly would make sense. The next thing we did was begin to look at faculty to student ratio, and again, it's difficult to manage this. And although we collected information from faculty reporting that they taught PEDS content, this was the important information, 55% of the schools report a ratio of greater than 1 to 11. The ideal ratio we all have had in our heads as we went through programs is like 1 to 8, but ratios we know have increased as we've gone forward. And you can see in particular areas, there are even 14% of the programs reporting that they have a ratio of 1 to 20. So that's just a little bit of beginning to raise the level of alertness about this content as we went forward. Then we began to look at taking that concept of an ideal faculty to student ratio and exploring it, describing the ratio and exploring it in terms of undergrad and graduate programs. And you might think that bigger programs with more faculty might have a better ratio, but this didn't seem to be revealed. So we set up a scenario to investigate the impact of what we called the common or traditional faculty to student ratio, which is 1 to 8, and look at definite program differences. And so this is a statistically significant profile of faculty to student ratio by programs with an undergraduate concentration only versus graduate and undergraduate combined. So that it tends to be that if you're in an undergrad program, you have a better student-faculty ratio. Again, this is preliminary data, as Anne Marie talked about. This is an onion in which we're beginning to peel back the various layers, but this was something that was interesting to look at. The next thing we looked at is asking about the average number of nursing faculty with undergraduate teaching responsibilities. And one of the things that's important to understand about this report of 5.3 teaching pediatrics per program is it's actually artificially low because we had a range of responses that we collected in a checkoff box. And Deb might remember this. You could check off, 1 to 2 faculty, 2 to 3, 3 to 4. And then we had a box that says 5+. But part of our data analysis, we got 107 of the 344 programs reported that they had 5+ faculty. So in order to sort of grab hold of a concept of faculty-student ratio in terms of pediatrics, we decided to just level it at 5, even though 107 programs said they had 5+, and using 5 as that response area, we calculated 5.3 faculty teaching pediatrics per program. So that's probably, again, artificially low. There's probably more faculty teaching peds. So that's important to remember than 5.3. And we asked them to sort of talk to us about what their responsibilities were in terms of clinical teaching, classroom, and so on. And so there's the description there. Oh, yes.
So I have a couple questions. One is, are you talking FTEs or are you talking full and part-time?
This was actually full and part-time, all combined.
And then when you say the faculty to student ratio, are you talking about clinical or are you talking about didactic?
We actually asked for just overall, we asked for how many students you have, how many faculty you have part-time and full-time, and so we combined it all.
Okay. Thank you.
Yeah. The next question we asked was, within your undergraduate program, tell us about the faculty that actually have a master's preparation in pediatrics and faculty that have clinical practice within the past 2 years, within 2 years, clinical practice themselves out practicing in the pediatric arena, not supervising students. We specifically had that in the questionnaire. You can't count supervising students in a clinical site as your own clinical practice. And so we got this report, and within interestingly enough, there is a real consistency between folks with master's or better preparation in peds and clinical practice. And they may be the same people or they may not. We didn't understand. But we looked at, understanding now that we've got 5.3 faculty teaching peds, artificially low, probably more, but only 3.1 faculty in undergraduate programs with recent clinical experience or specialty preparation in pediatrics. So there are people teaching peds that aren't prepared, or aren't masters prepared in pediatrics. Overall, we looked at where these faculty are in terms of percent of schools, and we found that most schools only had 1 or 2 faculty with masters or better in pediatrics and clinical practice in peds. Larger schools with lots and lots of faculty seem to have fewer and fewer with peds and preparation as well as practice in peds. Just an interesting observation. We also look at programs with certain attributes and to begin to better understand where these faculty are with preparation in peds and recent practice. They tended to be in very large size, Northeast region, both graduate and undergraduate programs, and part of an academic medical center with no relationship to source of funding as part of that. We next looked at the concept of how difficult is it for you to recruit qualified faculty. And folks completing the questionnaire, we asked specifically for folks to complete the questionnaire that had undergraduate teaching responsibilities in pediatrics. That was the directive in all the email messages. The messaging went primarily to the director of the program or the dean, and then got filtered down to other faculty. But of the responses that we had, the 344 programs, those were actually filled out by the faculty saying that they did have pediatric teaching responsibilities. So interestingly enough, we found that there is a great deal of difficulty, moderate to extreme, in recruiting faculty, and this is probably not very surprising. And then we found that there are as many as 25–26% who have no difficulties. That alarmed Anne-Marie so much that we actually had to do some additional analysis as to who the heck are these people that have no difficulty getting faculty. Well, son of a gun, they're in the Midwest, where Anne-Marie is.
Not my Midwest.
And these are their attributes, of folks that have no difficulty in recruiting faculty. Interestingly enough, they report more than 30 hours of classroom devoted to peds, more than 65 hours. And they still see competition for clinical sites as a very significant barrier. It's kind of interesting. We'll get into the curriculum concepts going forward, but that was kind of interesting. We also asked faculty to provide us some added comments about their experiences in recruitment, and more than 50% chose to respond, and the #1 prevailing issue was the inability to find qualified faculty, both part-time and or full-time. Pretty pervasive. Salary issues also emerged because as you do attempt to recruit faculty, clinical practice sites, particular hospital-based sites, are now paying fairly nicely for clinical expertise in pediatrics, so that there was a great deal of competition there. And hospitals were beginning to create their own plans for managing really a pathway or a way of sustaining pediatric specialty practice within their institutions. So they were taking their baccalaureate grads that seemed to be very good and smart in pediatrics, pushing them into a master's preparation as quickly as possible, and then reeling them back in to come in back and teach. And so that was also an interesting response. Any questions about faculty? Again, somewhat difficult to describe ratio because of the way we collected the data, but still some interesting results.
One thing I thought was nice, I thought was positive, is one of the questions asked in terms of barriers were your colleagues, were your other faculty members supportive of you? And they really were, because, you know, again, in the world of academics, it may be that the Gero people or the med surg or the psych or whatever don't think that peds is important, but that didn't come out at all. In fact, they also got you got the sense from looking at this that the rest of their colleagues were as supportive as they were of trying to have pediatric content and pediatric faculty.
Right.
Comment?
Yeah, I have a couple questions. One is, did you find out the age range, or did I miss
Of the
that?
faculty, no, we did not collect that. National data tells us that the average age for faculty is around 50, 51, something like that. Graduate faculty, I think. Joan's got her handy-dandy AACN frequent facts But I think that it is above. It's older than 51. Yeah, yeah. 53.
And,
All fact. Yes, Ann? Yeah, okay.
no, go ahead.
Yeah, we're basically all on the downside of the bell curve.
The other question is did they talk about cross-teaching? Because you seem to focus on that, and then I have another question, too.
Right. We're going to, as I get to the curriculum, we're going to talk about barriers and content. This is the meat right here, the curriculum. And so cross-teaching was what resources do you use? We actually asked that, so let me get to the data, and then we can then tease that out.
And the other thing about what we're experiencing with some of our students is there's an increase in the BSN to PhD programs. So you may have faculty who don't have a master's degree.
Well, we said master's or higher.
Okay.
We did. The question was master's or higher. Very good.
Janet?
Yes.
When you looked at the Midwest or some of the other areas, did you profile any of that type of economic data?
No, we did not. No. We really just focused on the pediatric content, but I think that's, that it would be an interesting sort of cross-analysis, cross-tab analysis of, if the Midwest happen to be where there's rich resources, highly endowed programs, and so on and so forth, that certainly would play into how faculty are distributed in the preparation as well. All right. Yes, whoa.
I'm sorry, just one more.
Sure.
At Maryland, the University of Maryland, we have a course that has been developed. It's a certification it's 3 semesters for teaching in health professions. And you take that, and as I understand it, it's required to teach undergraduate and graduate level at any point in time. If you get your DMP, you have to have it. I don't know how they're going to manage with the master's. Is that something that's taking off? Did you think about that at all? Because I know you're the certifying people, so.
Well, right. There is a certification for faculty that the National League for Nursing has put forward. But the program at the University of Maryland is familiar to me because I used to teach at University of Maryland, and it's really about taking a master's clinical, highly prepared clinical expert in nursing, and then teaching them how to teach. It's a pedagogical kind of approach to making sure that an expert clinician can then begin to take that knowledge and translate it into teaching adult learners. So that's generally the 3 courses. And the certification for faculty is related to that. So the content that's delivered is not clinically specific to peds gerontology, or any of the other body parts, body systems, or what have you. It's really related to the discipline of education. So it's kind of interesting. But it is something that is now growing because we don't have faculty, so we're trying to scoop up those clinical experts from a variety of sites and pull them into the academic setting. Absolutely. Any other questions? Yes.
Hi, I'm interested in the rationale for the question about faculty teaching peds with clinical experience within 2 years. Is that a preference, an expectation, or?
No, it was simply an attempt to describe a level of preparation based on recent childhood health conditions, because children's health care changes from year to year. There's we went through the SIDS scare and this scare, so we thought that in order to better understand whether there were experts on the ground to be able to teach peds that probably having a recent experience in a clinical practice in pediatrics within the past 2 years would be a good indication of being able to say, yes, there were people who had had their finger on the pulse of what was going on in children's health because they were clinically practicing, and or they were masters prepared in a pediatric specialty, and that counted as well. Whether that person, master's prepared pediatric specialty, was the person with recent clinical experience, we could tell but didn't do that analysis.
It seems like if a goal is to have that recent clinical experience, then everyone would almost have to be part-time in order to maintain that.
It really wasn't a goal. It was just a way of trying to measure whether there was knowledgeable a way of sort of capturing knowledgeable preparation to teach peds kind of thing. In the advanced practice community, there is a real strong, not necessarily initiative, but a strong requirement that clinical practice be a part of your armamentarium to continue to be active in nursing. Marion.
And I'll talk a little bit more about this later, but I think we have to be very careful how we define clinical practice.
Yeah.
Frankly, I have faculty who work as staff nurses at IU Health. That does not mean they're cognizant of child health issues.
Right.
What they know is about that unit and what's going on in that unit and whatever technology's in that unit. And of course, I have a real issue with this, but because I think things like nurse-sensitive outcome indicators and all the stuff we're doing on the Research Council over there and trying to move quality of care, that doesn't get translated as well as one would like it.
Right.
So I would just like to see our faculty in different roles in the hospital if they're working. And I don't think, well, I'll talk more about that later.
No, I think
So
that's
have
great,
to-
but we
Yep.
simply, and again, we, as Anne-Marie talked about, we designed the survey, not just closeting ourselves together, but we really got input from a lot of people. And the idea was to, and it was really open-ended, who within your program, or do you or anybody have clinical practice in pediatrics within the last 2 years? And it was they could define clinical practice however they wanted to.
And we did have the discussion that you both are alluding to, which is the difference between a faculty member teaching the didactic versus teaching on a unit with a clinical group, and what the needs would be
Right.
in those two groups. So one would argue maybe that if they're going to be on the clinical site, they probably should have been in the clinical setting recently, but that the didactic, that it may not be that they need that kind of practice, but they need the kind of practice that Marion's referring to. So I'm not sure we teased that out as well as we could have in the question, but.
Right.
hard
But,
to do.
I mean, it's just interesting to see, here it is again, faculty with masters masters or more in pediatrics and recent clinical experience. And there seems to be, some trending here, lots of programs with lots of faculty with not a whole lot of folks specialized in peds or recent clinical practice. Smaller numbers of faculty, probably in smaller programs, with that. Don't know why, can't really explain it, but it was an interesting observation. All right, let's talk about the curriculum. One of the things we ask folks to describe is how they deliver content in pediatrics. Within your undergraduate program, where is it delivered? Do you have a standalone pediatric nursing course? And we sort of got a definition from the AACN as to what that meant. Was your content in pediatrics sort of integrated through a variety of courses, because we know that there is a trend in some curriculum to concept teaching? And so was this, if you had a concept about lifespan, was there pediatrics included in that? Or was there some combination? And again, it pretty much fell out 50-50. About half the programs seemed to have a standalone course, and the rest seemed to have it integrated, and even some have both, standalone and so on. We then began to look at the total number of pediatric classroom and clinical hours. And a lot of us can remember from our school days that if you had a 3-credit course over a 15-week semester, that adds up to about 45 hours of classroom time, seats in the chair, listening to a lecture, 45 hours. Interestingly enough, the mean is a little bit less than that. But the range goes all the way up to 136 hours. I'm just thinking of how much tuition you'd have to pay for that many hours. Clinical hours, we also asked, and again, if you talk about 8 hours a week of clinical in a pediatric course over 15 weeks, it's about 120 hours. And the range was all the way up to 225 hours in pediatrics. Again, we're asking specifically peds, but the mean was 83, a little bit lower than the 120 hours in a clinical practice. 8 hours a day and again, I'm old nurse, graduated in the early 70s, and so I can remember having a pediatric clinical day, 8 hours. But that doesn't seem to be quite where we're at least per this report. What we also looked at, was particular pediatric content. And there is a list here that you have in your handout, and you shouldn't be looking at this. This is not quite the right slide. And we'll go over this. But these were the topics. Just pay attention to the topics first. We looked at pediatric genetics, genomics, nutrition, and this was where we really got with our colleagues and we said, okay, what is the content that needs to be included if you're talking about pediatric content in an undergraduate program? And so this is what we came up with, and you'll find that on one of your slides in your packet. So those are the areas. Does that look pretty comprehensive if you look at that list?
Do we have in our packet the previous slides of this, Jen?
Yes, yes, you do. Yeah, you do. And so one of the things we looked at is all those particular topics. I think there were about 13 of them. It includes everything from, acute care, emergency care, environmental, genetics, chronic illness, nutrition, mental health, all of those kinds of things that we know we ought to be teaching in peds. So we asked programs, please report to us the number of hours of this content in your undergrad program, not necessarily in your pediatric standalone course, but throughout everything. So count it if it's integrated, count it if it's standalone, count it if it's both. And we got that 67% of schools, and if you add the fact that 8 schools have 0 hours, we're talking about 75% of schools have less than 2 or fewer hours in pediatric genetics and genomics. But we know that that is a particular sensitive issue as we take care of kids in a variety of areas. So that's the data. As we looked at child and adolescent nutrition, again, 3 schools have 0 hours of nutrition. Add that together, 60% of programs have 2 or fewer hours in child and adolescent nutrition. You can all suck wind now. You can go, it's time to, yeah. And we'll continue. Pediatric environmental health. We're talking about, toxicities, environmental threats, lead. Again, 73% or 63% have 2 or fewer hours in the entire undergraduate curriculum.
Question?
Yes.
Do you have the names or the position titles for who completed these things? Because I'm thinking about the person at my school who completed it, and I'm sorry, I like this person. But she's one
We're
of those
taking
adults-
names. We're
she's
writing
an
them
adult
down.
person. I don't think she knows what pediatric environmental health is.
Well, we asked the person who's responsible for delivery of the pediatric undergraduate content to
I know, but
fill
I'm
this
just
in.
saying, the person,
Yeah.
we need to know who filled these things out, because they may not know what this topic is.
I understand. I share your passion.
I would just, in thinking about this, and I think this is a helpful baseline, but I would encourage everybody to think about it because there is no comparison. I would dare say, and I don't have the answer to this, but some of the newer topics, and it's what I'm going to talk about later, in looking at this as a foundation for discussion and to look at opportunities for where you can enhance the curriculum. But I would dare say that environmental health, that could potentially be all the environmental health that's in the curriculum, or a majority of it. Genetics, how much compared to pediatrics versus how much genetics? Some of these newer areas that are really enhanced and part of the new baccalaureate essentials. So I think we need to take this with knowing what it is and that what you're comparing it to, and also with the notion of who filled it out because of the whole mechanism. But you're absolutely right, and that's one of the issues of doing any curriculum survey.
Right.
Who completes it and who really knows what's taught in the courses and how much is how much. So, but I think it's a good foundation for a discussion
Right.
and about to look at opportunities.
I will
To us, was it
yeah.
a million more questions?
Yeah, it did.
Just like
It
this,
did.
it's like, whoa,
Absolutely.
that's all they're doing.
But I wouldn't necessarily take it as a scientific, accurate number. And also, you're not, you know, what are we comparing it to? So.
Well, I understand. We did make a tremendous effort, and Judith is here, and she'll correct me if I'm misspeaking. We collected the name and address of everyone because we did want to send them a copy of this to thank them for their time. And uniformly, we had wide, almost 100% participation. And we also asked at the very end of the questionnaire, are you the person that actually teaches peds? And they had to say yes, no. And so they said yes. So all the responses were the folks who are teaching peds. But yes, I think Joan's point is important. We're talking about emerging areas for content that need to be fully explored. And so this is, again, this is what they've reported. And again, we have a 66% representation of undergraduate education, which is a very profound reporting database. So I think we're okay to begin to make some judgments about where our focus might need to be for the future. Okay, child and adolescent growth and development. We know that that's an area in certification that's not often performed well, and still we have fewer than 4 hours in the majority of programs in growth and development.
And this is another one. When I saw that one, I thought, well, in our curriculum, we have a standalone course that they all have to take, and then maybe the person answers this in addition to that. So I don't know. You know, maybe there's more than that than this is capturing.
Right. Child and adolescent behavior mental health. This we know is a growing issue nationally. We heard from our wonderful colleagues in school nursing about the pervasiveness of this problem in their population and also in children's hospitals. And what we are finding is that 49% of undergraduate programs report to us they have 2 or fewer hours in child and adolescent behavior mental health. So it's an area, I think Dr. Elizabeth Hawkins-Walsh is a wonderful specialist in this area, as is Deb Gayer. And so we know that at the graduate level, this has also been an issue in many P&P programs. So it's also, we see an issue that we need to be aware of in undergraduate as well. Child health promotion and well child care. Still some distribution into the higher levels of hours, 5 or 6, 7 or 8, but still the majority reporting fewer than 4 clinical hours. Family health and parenting, because we know parenting is an important skill. It's hard to know where that's going to be included necessarily in pediatrics or in a community course or what have you. But again, still not enough hours when we know how pervasive that problem is. And you know, we in the certification world have found that in terms of parenting or particularly mental health, the content on our exams nationally, you know, when I was there 10, 15 years ago, content on our exam for child and adolescent mental health was a lot less, you know, less than 20%. Now, as we've done a practice analysis and learned that all pediatric nurses are really having to manage child and adolescent mental health, content on our exam is now above 30%. And so we've changed our exams to reflect current practice and what's happening, but has undergraduate education been adjusted yet? And so that's something that we need to talk about. Jude.
When we're looking at these number of hours, and particularly if we begin thinking about comparing them to a similar content that would appear for, dare I say it, the adults population courses, do we have any benchmarks that we're using for this? As when we try to decide what would be the minimum level of acceptability? And because I think we just need to be careful when we say that 2 may not be enough. Well,
yeah,
maybe it will be. You know, it depends on the reinforcement techniques and other kinds of things down the road. I mean, of course, we'd all like more, but I'm wondering about if we've looked at what we're benchmarking these numbers against as far as other specialty areas or
the issue of counting numbers it is tough, and it's tough in advanced practice as well. And it really what we should be talking about is competency-based education, and we do that in certification through practice competencies, and so we've adjusted certification to reflect some of the new practice issues, and indeed it happens in, you know, graduate education's now, you know, focusing on competency based, and we have our competencies that you have, your standards of care. So So part of the discussion we want to have enriched by all of you here today is what are the issues? If these are the competencies, this is what the data seems to reveal, then how can we begin to improve things? Because not only is this data there, we're also hearing anecdotal information out the wazoo about issues that people have confronted and problems in recruiting faculty, getting appropriate clinical sites, being attentive to the new emerging issues in child health that we need to do it. So the faculty and the academicians are telling us this. Now we have the data to say, well, yeah, you know, you're not just crying in the wind, so to speak. Your colleagues are also reporting these challenges as well. All right, family health, school and community health. Again, not enough hours, still a little bit merging into the 3 to 4, 5 to 6, a little bit. Chronic illness and specialty care, boom. More than 13 hours, chronic illness and specialty care. Because most folks probably go to hospitals, and we'll find that out here in a minute. Acute care, 34 hours. 34% have 13 or more hours. So let's round that off. We said that there was an average of 43 classroom hours in pediatrics. That was our previous data. If more than 13 of those 43 hours are in acute care and chronic illness care, there's not much left. Critical and emergency care, not so much. The wide majority, less than 4 hours. And so that was all of our topic areas. And there's a slide that you will see, and I will profile again to sort of give you just a highlight of where all those seem to range. Yes?
I'm wondering where farm fits in.
I would dare say, and we didn't ask farm specifically, that it's all in here.
So it's integrated.
Yeah, I would think so. We didn't ask for information about a specific pharmacology, pediatric pharm course, or what have you. That's absolutely, I mean, pediatric pharmacology is certainly an issue in advanced practice, but in undergraduate,
Well, they're delivering the meds on the floor,
yeah, I would agree.
and there's a high number of med errors.
Yes, there are. And we're going to get some information about hands-on issues, challenges, and those kind of skill sets as we continue. So it's sort of one of the things we did as a sort of a summary question is, again, ask about pediatric classroom content. To discover where there might be pediatric content in other courses, we asked the faculty to sort of identify any other standalone courses that they might have that would have pediatrics integrated through them, and what percentage of hours and stuff that might be within that. And the large majority reported that there's not really much in the way of pediatric information in a health assessment course, or just 39%, 1 to 3 hours. Some said that there were 0 hours or it did not apply in their health assessment course. Family nursing, most didn't have a family nursing or had 0 hours related to peds. Community school, traditional maternal child course that often still exists in undergraduate education. Little bit of a more response about pediatric content in that. Again, the thing somewhat disappointing for many of us was the psych mental health course, which is often a standalone course still in many nursing programs. We would thought perhaps that might have some pediatric focus given the fact that we have a huge national issue about child and adolescent behavior mental health, and didn't find that much. 1 to 3 hours. Most didn't, had 0 hours or did not have a standalone psych course. We also looked at pediatric clinical experiences by these various courses as well, understanding that health assessment frequently has to have a clinical component as well as some of these others. And again, not much there in the way of support for clinical activities within those courses. So finally, we began to ask folks about their difficulty in securing pediatric clinical sites within the past 2 years. You know, is it hard? You have no difficulties, somewhat, moderately, extremely. And we looked at that in terms of academic medical center, how the content was delivered, standalone course, integrated course, number of faculty, number of students, pediatric faculties, or faculty that were specially prepared. And there was no correlation among those variables. The only association with difficulty recruiting faculty was clinical sites. Difficulty getting clinical sites and difficulty recruiting faculty were statistically significantly associated. So if you don't have qualified faculty, you begin to think then that perhaps your challenge as an undergraduate program will be that you can't secure the clinical sites necessary to teach these students. Just an association. Difficulty in finding clinical practice sites related to difficulty in recruiting faculty. Again, moderate to extremely difficult to find clinical. 67% of schools also identified moderate to extreme difficulty getting qualified faculty. So again, huge proportion, 67% difficulty getting clinical sites, also have difficulty getting faculty. If they don't have difficulty getting clinical sites, very few report that it's moderate or extremely difficult to get faculty, 34%. The next thing we did was begin to look at where are we putting our students clinically, what sort of sites. And so we've got, what, 15 or 16 different sites listed here, plus we allowed folks to write in sites. So Ann, as we were thinking about, you know, the creative folks that are doing different things in the community and child care centers and so on and so forth, we actually had child care centers listed as a number one site. Again, these are just alphabetically, but it was definitely where we thought pediatric nursing clinical practice ought to take place. And we, again, floated this by a number of experts to make sure that we were fairly inclusive, and we allowed write-ins. So where are students going? We asked faculty to rank the top 5 clinical placements that have accepted the most students within the past couple of years. So choose the top 5, and these were what we found. Number one site for 68% of the schools are pediatric inpatient medical unit. Is that surprising anybody? Pediatric surgical unit, probably same-day surgical kind of stuff too, specialty units. Pediatric ICU. I didn't think we let undergrad students go in there, but I guess we do. And then finally, elementary schools, and again, the pediatric ICU was identified as the 5th choice for a lot. That was they were sort of tied with 10% reporting that they go there. So only 10% have found elementary schools as one of their top 5s. We're all hospital-based, and we're all teaching acute care. Sounds like my nursing program, my pediatric course 30 years ago. Then we thought about, you know, there's a variety of ways to deliver content, both classroom and clinical. High-fidelity simulation is a huge, popular tool on many campuses today. So we wanted to find out what are the resources that are available to you for you to use to be creative in the delivery of your content. So do you use mannequins? Do you use self-directed learning? Podcasts? How about case studies? Multimedia. Multidisciplinary learning, which we think is very important. Unfortunately, for classroom delivery, it's not happening. Case studies, yes, are highly used. I remember using case studies as a student, myself in an undergraduate program, so that's still a valuable learning tool. Multimedia strategies, again, we left that definition up to the individual. So it could be something, anything more than a chalkboard could be multimedia by definition. And so, you know, that was a strategy, but again, not huge. So we're not, for classroom delivery, the creativity on resource use is challenged. How's that? Clinical teaching. Are we using new and different resources to do clinical teaching? Is there a way that we can have a video of a mom and a child interacting in a waiting room to display some behavioral mental health issues that we can use to teach students? We're not using it. We're not using self-directed learning, multimedia strategies in the clinical area, and the most disappointing is multidisciplinary learning. People are reporting that just doesn't happen. Some mannequin models are used in the clinical teaching, and so that's maybe a new and emerging trend. Case studies, again, also used in pediatrics. The next thing we did was look at some barriers, moderate or significant barriers. And we had a long list of barriers that included such things as, does your state board think that pediatrics is not an appropriate content area to be taught? Does your faculty, hate peds? Do you have this bias in your faculty of all these well-endowed gerontology folks? Monetarily so, not otherwise. Do they somehow have a bias against pediatrics? Let's see what our barriers are. So we looked at this in terms of those barriers that prevent the development and delivery of your pediatric nursing content, your responsibility to deliver this content. What are the barriers? Number one barrier is competing with other people for clinical sites. Well, if we're all in the hospital and all teaching acute care, there are only 200 some odd children's hospitals, standalone children's hospitals in the country, a lot of community units and so on and so forth. But yes, there will be competition. 76%, huge representation. Inadequate number of nurse preceptors also seems to be fairly highly reported. Lack of quality clinical sites. Again, this direct hands-on care, clinical learning opportunities with children, which I would say would include this medication administration kind of thing that would be included in that. And then, well, specifically number 5, limited opportunities to teach medication administration. These were all statistically significant reported. So we need to be aware of these issues and begin thinking about ways to solve these. Other barriers identified by most programs: number 1, competition. Number 3, where we had the statistically significant association, lack of quality clinical practice sites, greater barriers for small and medium programs, rural and suburban. These should not be surprising. Lack of programs not part of an academic medical center had much more of a challenge with clinical practice sites. Programs offering campus-only education. As part of our data, Dr. Judith Ryan and I had fun over a kitchen table looking at this and found that in Lynchburg, Virginia, there are 4 undergraduate nursing programs. 4 baccalaureate nursing programs. And so I don't even think there's a hospital in Lynchburg. So there's a challenge in getting sites. Significant or moderate perceived barriers related to high and low difficulty factor. Clearly, recruiting faculty was emerging as a major issue. So we wanted to look at that concept of faculty recruitment as highly difficult, which where we combined the moderate and significant difficult. Not so much difficult, so we put the not and not somewhat difficult together. And then we correlated that with the various barriers. And here's what we found. If you have high difficulty, moderate or extreme difficulty getting faculty, the competition for clinical sites is a major issue for you. Nurse preceptors is a major issue for you. Interesting, and I've got this, I better use it. This insufficient part-time faculty. So those people who had some difficulty getting faculty felt like having few faculty was also a barrier, both full-time, part-time. And again, this lack of direct care hands-on clinical experiences is a big issue when you have such a hard time getting faculty. More significant and moderate perceived barriers related to faculty with, again, faculty that have masters in peds and recent pediatric clinical experience. What are the issues for them? So we did a subcorrelate. Programs with more faculty with masters in peds or recent clinical experience had also identified as a greater barrier the fact that they didn't have any partners. So if they were there, faculty with masters and recent clinical experience, the fact that they didn't have any colleagues to be in partnership with in delivery of content was an issue. And if you remember the first slide where we said where 25% of programs have only 1 or 2 pediatric prepared faculty with a specialty in peds, either masters or above, or recent peds clinical experience. And programs with 5, 6, 7, 8, 9 faculty have almost no colleagues. We also wanted to make sure that we were really fully describing where pediatric content might be, so we asked, do you have an elective course in pediatrics? Maybe it's there. Maybe that's where the content is. But in fact, it's only offered by 12% of the programs, with an N of 42 out of 344. And it was often described as being open to non-nurses as well. So we didn't ask specifically for what the content was in the elective course. We just asked, did you have one? Did you include pediatric nursing in an elective course of some sort? Difficulty in meeting pediatric curriculum and clinical objectives for all BSN students. That was an important question. So we're now we're trending towards the end of the questionnaire, wanting to know, we've asked you about your content, we've asked you about your faculty, we've asked who's prepared in teaching peds. Tell me overall what your perceived level of difficulty is in meeting the pediatric content learning objectives that you think should be in your program. Is it difficult or easy? It wasn't very easy for most. It was somewhat or very difficult as the large majority of responses. And we're all nurses and we all take on burdens, and so when someone responds to me, you know, if I had a 2-hour commute, was it hard to get in? It was somewhat difficult. But it was really very difficult. So you wonder, again, different perceptions, but to me, somewhat difficult to very difficult is a revealing response. We also asked those folks to tell us, how well prepared do you think your graduates are? Again, we've asked them about difficulty meeting your pediatric learning, and they reported. The very next question was, great, they're getting ready to walk out the door. How well do you think they are to day one start taking care of kids and adolescents and families? And this is loyalty to your program and to your school and to your students. Is that by May they'll be prepared. Excellent to good. Interestingly enough, however, and Dr. Janice Smith will give you some interesting information, because then we begin to ask them about, well, where's pediatric residency in all of this? So Janice will be giving you some revealing, interesting comments. So perceptions about their RN grads, we begin to look at that a little bit more. Programs that report that it's easier to meet their pediatric nursing objectives tend to perceive that their graduates are better prepared. Well, that makes sense. And that's good, actually. Those who thought that their graduates were poorly or not really well prepared, only fairly prepared, thought it was somewhat or very difficult to meet program objectives. Statistically significant. Perception how well graduates are prepared was associated with the affiliation with the academic medical center. Meeting the pediatric nursing program objective, difficulty was either very easy or very difficult, were the responses from the privately funded schools. Either the privately funded school, and that interesting comment you talked about, where's the money? So the privately funded schools either found it really, really easy or very, very difficult. And that might, in fact, be related to that concept about funding. And it was somewhat easier if they were from public programs. Very easy, somewhat easy to meet objectives. 64% of those schools indicate it was not difficult or just somewhat difficult to meet faculty or recruit faculty. Difficult to recruit faculty, it was difficult to meet your objectives. We've always said if you have difficulty recruiting faculty, you're going to have difficulty finding clinical sites. If you have difficulty recruiting faculty, you're going to have difficulty meeting your pediatric learning objectives. Very easy, somewhat easy to meet the nursing objectives was interesting, associated with the number of clinical hours. The number of clinical hours was greater compared to those who indicated it was difficult. And the number of students was greater, interestingly enough. More students, more clinical hours, easier to meet your clinical learning objectives. And that might be this, the case studies, the seminar studies in which the students enrich each other in terms of content, just as an example. So now we're sort of getting down to issues for discussion, and I know we're getting ready to break here at noon for some lunch, and then we have a wonderful expert panel that we will introduce to you after lunch to begin to reflect on a lot of these. But clearly there was the difficulty recruiting qualified pediatric faculty was a big, big issue. Difficulty finding sites, a lot of other barriers to meeting these objectives. Classroom emphasis on areas that we think we clearly know are emerging healthcare issues for children. Didn't seem that they were appropriately reflected in terms of classroom content. And this was the summary slide in which I wanted to show it. 2 hours or less. We've highlighted those areas with 13 hours or more. There was actually a range between 3 and 6 hours, but there were so few folks reporting in that area. I think it was under 10% actually. So the large majority had 2 or fewer hours, 3 to 6 hours, or more than 13 hours in these content areas. And so that's, again, this is just information we need to look at, sort of digest, and begin to sort of appreciate. But one of the things that we tried to do is we talked about the school nurse exam and how they're dealing with emerging issues in school health. We wanted to also have everyone just reconsider, essentially, what the issues are in child health today. Preventive care is the most common reason for pediatric visits. Well child care is really a quarter of the time for most visits, particularly for the children under age 2. Proportion of parents who are reporting that they're asked about their child's learning and behavior is up to 56%, and the parents do have those concerns when they're asked. Again, they don't get their preventive visits as recommended by the American Academy of Pediatrics. Greater attention from the Commonwealth Fund. We need greater attention to children's chronic disease, to improve measures for asthma and diabetes care, and there is particular need for improved measures in assessing behavioral health. This is new data coming out, 09 and above, and so we're being asked nationally as nurses to focus on this. And so we need to begin to think about how we can prepare our population to continue to do this. And again, the top 5 or 6 conditions, 7 conditions affecting kids, 6 actually, are there for you. And this data is a little bit old, and we see almost 20% in obesity. If we were to count overweight and obesity, the percent would go higher. There's now some folks saying that obesity is the #1 chronic illness in many areas for children. It is also respiratory and allergy issues are very big, asthma, dental care, and again, now the ADHD and other behavior issues. So these are important national bits of data that should influence what we teach. And again, just as to reiterate, the knowledge expectations that we have in school nursing practice and in general nursing practice really sort of begin to deal with those kinds of things. We've sort of trying to reflect certification to make sure it reflects practice. And the question is this content in the undergrad programs? So, thank you for your patience with 72 slides. But I hope it was interesting and provided some food for thought. Question?
Actually, it's just a comment I wanted to make. I wonder if it would be really interesting to first of all, to know how many of the nursing graduates from a program, like where they go to work, the percentage of where they go to work, and then getting the perceptions of the people who employ those nurses in terms of how well prepared they are, to correlate with what the faculty's perception of how well prepared they are from a clinical.
Well, I agree. And there's actually some data. As we look at pediatric nurse residency, the National Council of State Boards of Nursing reports that 56 or 50 some odd, I can't remember the percent, of employers report that their first year registered nurses are not prepared. So we do have some of the employer data. Yes?
Well, just to build on that, just to see the graduates' reflection of how much time they think was dedicated in their curriculum to these
Right.
areas, it would be interesting to see if their impression matches what the institutions believe they are providing.
And I think it's fair to say there's probably a mismatch there. And again, as we have Janice talk about the pediatric residencies this afternoon, you'll see some interesting data revealed with that. Yeah, and I dare say that there probably is a disconnect between what faculty think their students are prepared to do versus what employers need immediately when they walk in the door, boots on the ground, ready to take care of patients. Yes?
I also ask each of us, most of us look like we've been around a while. The day I walked into the pediatric unit in the Army, I felt totally unprepared, and I had 3 times the amount of clinical that our students have now. I had outstanding undergraduate education. I would defy anybody to tell me when they show up for the first job that they feel prepared for anything.
I would agree. I would agree. I think it, and our profession reflects the need for continuous learning. And so continuous learning is taking place every single day. So if you're talking about a revolving door of continuous learning, at some point you've got to jump in the door and then join the crowd. And it's going to take you a while probably to catch up. But the hospitals are demanding immediate competency, and so there's probably a need for some partnership with their questions. Oh my goodness, lots.
I guess we're just having reactions over here. I think also because we would not expect when you graduated from medical school that you would be prepared to assume full responsibility for a patient's care. And so I think the residency program is addressing a gap that has always existed.
Right.
And what the employer wants and what the employer can deliver is probably more important.
Right. Yes, more.
I would say from a hospital perspective, we know what we teach people in their orientation, and we know they complete orientation and are still not prepared. So I don't think that hospitals have an expectation that nurses will be completely prepared when they finish their academic programs. I think we need to strategize together about what they need as a foundation,
Right.
and then how we together plan for what they need when they begin employment.
Right.
And I would agree with that. I think some of what we've done in education is to try to plug everything in so that you can't do it. We hire around 300 new grads, all pediatrics, every year. And those new grads go through a nurse residency program. And I meet with every single group of them, and one of the questions I always say is, how prepared did you feel to come to work here? And maybe one person will kind of raise their hand because they've done an externship or a special rotation, but there's no way undergraduate education can prepare you. Hopefully it will prepare you to be a critical thinker, to understand what nursing sensitive outcomes are, and to translate that into whatever practice you go into. And we probably need to hone in on critical elements versus continuing to try to push things into a curriculum that we don't expect it on the employer side.
Yes.
Sorry, I just had a question. Was there any way to look separately at the accelerated programs in terms of their pediatric content or clinical?
We did not look separately at that because, again, it was all about RN entry. So there are many programs. In fact, the original data, I think, showed that there was a significant number of second-degree programs. Again, this is not RN to BSN. These are just non-RNs coming in to become RNs. So our understanding was that they were going to have to meet the undergraduate curriculum objectives in order to become an RN.
Right.
But they may perform differently, I would agree.
Right. I guess the reason I ask is we're all reflecting a lot of anecdotal information we hear, which is why it's so important to ask these questions. But we certainly hear that there are many accelerated programs that have shortened pediatric clinical rotations. And I just am curious to know whether that's grounded in any kind of facts or it's just one of those rumors that we keep passing back and forth.
Well, again, interesting to see, there was a large percentage of accelerated programs, and the mean number of classroom hours and the mean number of clinical hours were less than what has been traditionally described as a standalone pediatric course, 45 hours, 120 hours in clinical. And we had 83 clinical hours as the mean and 43 classroom hours. So clearly there are fewer classroom hours and fewer clinical hours that have developed than 30 years ago, 25 years ago. So I don't know, you know, we know where they are. We know the top 5 clinical sites where they're going. They're all in hospitals. So it's you know, I'm not sure about the accelerated program and what have you. You know, we do hear a lot of clinical stories about it's time for the students, particularly in those small cities, Lynchburg with 4 programs, where they go into the community hospital that has maybe a 7-bed pediatric unit, and guess what? They don't have any patients that day. So that's when they go down and they do case studies or some other different strategy in order to check off that pediatric rotation. So those kinds of stories we do hear. The data seems to reflect that hospitals are still the primary focus for clinical rotations in pediatrics. And I think there are ways to do that differently and perhaps enrich clinical learning, academic learning, pediatric competencies through other strategies. And if I had to have a personal reflection on what this data seems to show to me, it looked like my pediatric nursing course 30 years ago. And now that I know that the faculty are really rising above the age 56, I dare say that the pediatric faculty that taught me is probably still there.
Just to answer your question, I'm not sure. I think I'm going to go back and look and see if we can tease that out, because we may be able to look at just the accelerated program. So I'll talk to Judith about that, because that's actually a good question. I've heard also anecdotally, and our experience has been that they've cut out peds in those programs because they're trying to rush them through, so they tend to focus on adults. And in our program, they focus on adults to the exclusion of peds and gero, and so we've had some discussions about that. So I need to go back and look at the data and see if we can actually tease that out. That's a really good comment. So.
This is a question you probably didn't ask, but if students do not have experiences in pediatrics, how many of them choose to go into pediatrics?
Yeah, that'd be interesting.
And that may be part of the problem that we're having with shortages, because personally, again, anecdotally, students who do not have experiences in the clinical areas will not choose those clinical areas.
And there are programs that allow choice. For example, everybody has to do kind of a classic adult, what I think of as med-surg, but they might be able to choose between peds and gero or community. Well, most of them still require community, but there's some pick and choose. And so, if, like you said, if you don't do peds, do you go into peds? And if you don't do peds somewhere along the line, will you ever go into graduate education in peds, which for me is really scary.
Right.
You know, question.
Yes.
I have to push the button. So from my perspective, because I'm a primary care pediatric nurse practitioner, it's difficult when you see the slide that says how many pediatric nurses are functioning within institutions. You have this growing gap because the technology within the institution is just getting incredibly complex. And so, and yet the majority of children are not there. So then we have to start to make decisions in less didactic hours. I was trying to count up how many didactic hours we actually have in peds at ASU, because it's an integrated curriculum. Very few clinical hours. So how do you prepare them? Because I think we're going to need to start making a choice. Do you prepare them for this intensely technological, very difficult environment? Or do you more broadly prepare them to take care of children in multiple settings in which nurses currently are not employed in taking care of them? So I think that the problem, that gap, having said that, this group is incredibly important, because I think that if we continue to struggle with that, then this thought about pediatrics having less and less content and less preparation that hits us in our advanced practice, they're less and less prepared, and yet we have to give them more and more information. You know, you reflect on some of these national statements, and then where are the pediatric competencies, and how are they getting developed, and what is going on? And it almost feels like pediatrics is getting shorter and shorter shrift across the nation. So I think while we have those struggles, we need to unite together and be a united force in order to encourage pediatric education. So that's just my thought.
That's good.
Yeah, and for me, looking at this data, I was trying to set aside my biases because I'm a psych person. So I was just appalled when I looked at the psych piece. And I've actually, in the not-so-recent past, gave a symposium to the nurse practitioners in our state on mental health and all this kind of stuff, on assessment. And since I had educated many of them and I could see they were looking green at me, I sort of said, what's the problem? They said, we don't want to assess for mental health problems because we have no place to refer them. And we have no skills to take care of them. So my passion is mental health. But when I look at this, I'm trying to decide, so what do we need to have in a curriculum for generalists? Because we're talking about something that we're saying every nurse should have, we're not talking about what every nurse who's going into pediatrics should have. We're talking about what should be in this undergrad curriculum for every nurse, which is a little bit different for me than the people that are going to show up in some of these children's hospitals per se, because you're right. Their education is going to be a generalist peds education. So what is it that they need to have? And so I struggle. I'm not sure. And I had the same sort of response that Jan did. I looked at it and I went, oh my God, they're still doing what I did, 20, 30 years ago. And then I thought of some of the people I know that are teaching didactic pediatrics, and oh my God, they were teaching 20 or 30 years ago.
And we say, thank God, there's somebody
So I don't know the answer, but I think this is, as Lee was saying, I think this is a good group to sort of step back and think about that. And remember what we're talking about now. We're not talking about the residencies quite yet. For those who are passionate and want to be peds nurses, we're talking about what should every nurse know about pediatrics. So it's a slightly different perspective.
And my colleague, Dr. Mary Jean Schumann, talked about, nationally there's a focus on population health. And so the fact that we are describing opportunities for accelerated RN students to opt out of pediatrics as a population within their nursing discipline, that just doesn't seem right. But that is an interesting, yes.
We certainly know that's done in many European countries where peds is an option. But this is shifting gears a little bit, but it's making me think about something else that I think we can maybe think about in the future, and that is the problems perhaps that we as faculty have in being as knowledgeable and competent as we need to be in using, for lack of better words, I'm going to use the word alternative pediatric clinicals as truly good learning experiences for students. And thinking about a survey that was done recently that I participated in for the National Training Institute on Child Health Care Consultants. And they were concerned about this sense that more and more programs are sending students to daycare settings, child care settings, for easy pediatric experiences. And that's why the numbers here will be interesting to look at. But there has been this sense that it is easier to get numbers of students into a Head Start or a child care center or daycare center and give them some exposure to growth and development and that kind of thing. But when they looked at the knowledge of the faculty in terms of, are they aware of current standards about care and of children in daycare settings, and in other words, instead of just using it like a setting where people could be exposed to children, but really understand what current expectations were, what recommendations were, what the guidelines are. Faculty were not nearly as knowledgeable about these things as we would like to think. And so this idea of putting students in less traditional setting, even though faculty may not be relatively experienced with all the technology in hospitals either, they're probably more comfortable, many of our faculty, in hospitals than they are in going into a setting that perhaps they were not educated in, they were not comfortable in. If they have not worked in it, they may not have the repertoire of
Right.
that they need
I'm
to
glad
have.
you mentioned that, Liz, because within the executive summary that we've had prepared for us, there's actually an area that I don't have in front of me, but that talks about if you are have identified yourself as being specially prepared in pediatrics, masters or above, you're still challenged to get clinical sites, but not as much so, because there is the implied scenario that you've been creative. because you know what is necessary to teach to students, and so you've been creative in the way you've marshaled clinical sites for those students, other than the traditional hospital-based four walls.
So this is fantastic that we're having this passionate discussion, and we'd like you to continue it over lunch, which we're now going to take a break and have
All right,
lunch.
we got one question, please, go ahead.
I just have one more comment, and I think it behooves all of us in the practice of pediatrics and in educating nurses that we challenge those students of ours and those colleagues of ours that nursing really is a lifelong learning process, and we don't owe it to the new people to come to provide them with all of the education that they need to work at the bedside, that's part of their responsibility to go and seek those, so.
Exactly, and that's, Dr. Michael Bly talked about that as a major issue within the IOM report, making sure that we recruit students, they clearly understand this is lifelong learning. This has been wonderful. I hope you've all enjoyed learning about the research that we've done. It will be nationally published. The video and all the slides will be available for everybody through the website, so please jump in and have access to that. We want this discussion to be very rich as we continue through the rest of the day. And while some of us has been concerned that we are sort of airing our dirty laundry, that we're not teaching as much in child and adolescent mental health as perhaps we need to, I think we're going to be able to walk out of here with some interesting perspectives and solutions, potential solutions as we go forward. So as people read the research and become shock and awed, so to speak, we will also have a plan for resolving any issues that we think are important to address. So thank you very much. Enjoy lunch.